Good evening, everyone. We're excited to have our second virtual Thursday. Tonight's topic is experiences from the front line as we continue now by Bob McIntyre, class of 1981. Bob is chairman of medicine of South Shore Hospital. Bob graduated from Boston University School of Medicine in 1993 and completed his training in internal medicine at Boston Medical Center in 1996. He's been in practice for 24 years, initially as a primary care doctor in Waltham, and since 2012 as a hospitalist. In 2016, he became the medical director for the hospital medicine program at South Shore Hospital, and in 2019 became the chairman of medicine. He continues to see patients admitted to South Shore Hospital. Dr. McIntyre is a board certified in internal medicine. He's an internist with 20 plus years of clinical experience in outpatient and inpatient settings. Dr. McIntyre has been involved with operations and strategic planning throughout his career and has served as an officer of several different PHOs and as well as a member of board of trustees at several hospitals. As a hospital-based clinician, his practice is dedicated to providing high-quality, evidence-based, and efficient patient and family-centered care to patients with complex medical conditions while they are at the hospital. Dr. McIntyre served as a captain of the Medical Corps in the Massachusetts Army National Guard, providing medical services to soldiers during times of active duty. Very early in his career, he was a research assistant at the Veterans Administration Medical Center in West Roxbury. He is published as a co-author of a clinical research journal and has given many presentations to a range of audiences. Over 20 plus years, Dr. McIntyre has been on numerous committees at hospitals, and he's practicing and serves on the Medical Executive Committee and several other strategic planning committees for South Shore. Dr. McIntyre is a graduate of Catholic Memorial from 1981. Three of his four brothers are also CM alumni: Stephen, 1987, James, 1990, and David, 1992. Dr. McIntyre, his wife Susan, and four sons reside in Westwood. In his community, he was a den leader for the Cub Scouts, a volunteer coach for youth basketball and hockey. And he's provided medical oversight for the youth football programs as well. We're also joined tonight by Dr. Tim Murphy, class of 1983 and current parent of 23. Tim is the medical director of the Weston Primary Care Group. Dr. Murphy graduated from Boston University Medical Center and has completed his training in internal medicine at Boston Medical Center. He is board certified in internal medicine with the American Board of Internal Medicine. Dr. Murphy is also the medical director for Seasons Hospice Palliative Care's Boston office. Dr. Murphy started Weston Primary Care in 2017. In 2014, Weston Primary Care converted to a concierge service. Weston Primary Care's concierge service has developed a strong reputation as a premier practice in Metro West area with 24/7 access and a commitment to the highest quality of care. His practice specializes in both adult and geriatric medicine. He refers to Newton Wellesley Hospital and MGH, but will refer to any specialist in Boston area if they're right for his patients. He has been an instructor of medicine at St. Elizabeth's Medical Center, Boston College Nurse Practitioner Program, and is an assistant program director for Mass College of Pharmacy. He teaches both internal medicine and geriatrics. He enjoys difficult diagnoses and managing complex cases, but especially enjoys being a primary care physician for his loyal patients, some of whom he has been managing for nearly 20 years. Dr. Murphy is a graduate of Catholic Memorial class of 1983, and his four brothers, Christopher, David, Edward, and Philip, are also CM graduates. He is the father of four wonderful children, including Aiden from the class of 2023, and the husband of the accomplished Dr. Marianne Murphy. He enjoys spending time with his extended family, sailing, playing beach volleyball, chess, family game night, poker, and reading a great book. So I'm excited to welcome these two gentlemen here tonight for hopefully an engaging conversation. We're going to open up at some point in the call tonight for some questions. The chat function is available. We have a number of questions that people have sent in prior to tonight. So I want to start out with my first question. First, it's a great pleasure to have you guys here and to pull you away from the work that you're doing. I'd love to hear initially, Bob, and then followed by Tim. What was your initial reactions to this coronavirus, and when did you begin to realize that this was really changing very rapidly and becoming a pandemic? And how has that perspective or your thinking evolved over these last few weeks? Bob, what are your thoughts?
Well, first, Peter, thanks very much for inviting me to participate. This is a great opportunity to try to tell people about what's really happening. I think the first reaction that we had was as another news story. So when things were breaking late December and January, Australia had its fires going, and the whole talk about this new virus in Wuhan. For those of us who've been around for a while, it didn't seem to, how much was really just the news blowing things out of proportion versus a real problem wasn't clear. So if we go back to Ebola in the late 90s and SARS-1 and MERS and swine flu and avian bird flu and all the other stuff that goes out there, there's always this big publication because people get excited. I think that really changed when it hit the west coast of the U.S. in the state of Washington, because all of a sudden it was here, and when we started hearing things locally, and then they showed up in New York, we began to realize that this is going to be a real problem. Certainly, in terms of how perspective changed, the initial stories coming out of Italy and Washington were quite frightening. Talking about people being completely overwhelmed, not having enough beds, not having enough ventilators, and the mortality rate initially reported was really high. And a lot of that had to do with, I think, if you test one person and they're positive and that person dies, the death rate's 100%. So nobody knew at that time how many people actually were infected and never got sick. So over time, what we've realized is that there's a lot of people out there because they were never really sick enough to be bothered. So other things that have changed is that we've had a lot more understanding about what we can do, and the preparation that the governor made, and I have to give him credit for that, by the social isolation changed what could have been a tidal wave of sick patients, which would have overwhelmed us, into more of a high tide. And so consequently, we've been able to do more because there's less sick people.
I had learned a lot from the H1N1 experience of how it started in Mexico and traveled across the country, because I was running my practice at the time. And I learned a lot from that, which from the virologist at the time, saying that you really can't contain a virus. Once you know it's, if it's transmittable by respiratory droplets and it's community spread, it's going to be very, very difficult to contain. As opposed to like Ebola, which really is through blood droplets. You have to have very, very close proximity to somebody to get the Ebola, which is actually much higher mortality rate. But with the respiratory droplets and community spread, we know that it's really not, you're not going to be able to contain it. So I actually noted the China report to the World Health Organization, which was reported on December 31st, and that perked my interest right away when I saw that. It was a very, very small little story, but I noticed it, and then it started to pick up spread. And then by the mid to late January, we knew we had a high suspicion that it was community spread. And my daughter remembers that I started to create a can and dried goods shelf in the basement in early February. And I started sending out my messages to my patients in early February that we were going to be in a pandemic, and that we may have, problems with supplies, and start preparing for medical, having them to have their medicines at least a 2-week, if not a month supply. We're now doing, everyone's getting 90-day supply. So we started to have this sense that this is where we're heading, and depending on which part of the country you were and so forth, when it was going to hit, but we really knew that it was going to hit. And it just was slowly evolving.
Tim, maybe shed some perspective. We definitely have some students on there and some parents. Talk a little bit, just for a brief moment, about the complexity of why a virus is different than a bacteria, or how we would treat other aspects of a cold. What makes this so difficult?
Well, because of the size of the virus, I mean, I think it's probably maybe 1/100th of the size of a bacteria, and so it can actually travel so much farther than a bacteria. Bacteria really is transmittable by very large respiratory droplets, while viruses, being so small, can be transmitted almost on just dust molecules, or almost to that same extent, in the air, can stay floating in the air for a very much longer period of time. And it can actually live on inanimate objects for a lot, doorknobs and railings for a larger period of time. So I think that it's the transmissibility, because of its floating in the air and can actually travel a certain distance. That's why we're talking about the 6 foot distance. And we don't even know if that's accurate. I mean, we're still only 4 months into, 4 or 5 months into this disease. And there are diseases now that we're learning a lot about that we've known about for decades. So we're still in the very, very early stages of understanding everything about this disease.
Well, when you think about the collaboration between hospitals or different organizations, how has this been different than what you've seen in the past?
Well, I think there's been a lot of differences. The first is, just to add on to what Tim said about the difference between viruses and bacteria. So bacteria are single cell organisms, create their damage by being outside of our own cells. And so you can marinate the body in things like antibiotics, and you don't have to worry about what happens about them getting in the cells. A virus, which is some RNA or DNA wrapped in a protein core, punctures the wall of the cell and creates havoc inside the cell. So the difference is similar to if you were going fishing, say trout fishing, and had a fishing rod and a deer walked by and you said, aha, I'd really like to have some deer meat. You have a problem because a fishing rod will do no good whatsoever. So all the antibiotics, is why I don't give antibiotics for the common cold, because it's not going to help it, so it can only make things worse. But in terms of what's happening is that a lot of what has changed has been just from come to work about whether or not you have colds or don't have colds. All interactions are minimized so that families aren't allowed into the hospital anymore, because we don't know what they might be bringing in and they might be infecting people. We are all reusing things that were disposable 3 months ago, and trying to come up with ways to sterilize them because supplies are low. But I think from a treatment point of view, the good news is, especially given what was coming out of Italy with the tragedies of all of these people dying, is that a lot of the anecdotal things that might have worked, high dose vitamin C, or what's they use for chloroquine, or some of these other things, is that we've learned that the illness really has 2 parts. One is the acute infective part, where the virus is attacking your body and your body's fighting back. But the second part is when your body overreacts to that virus and you get what's known as cytokine release syndrome, or cytokine storm, where your own body's attempts to fight the virus now starts destroying the body. And so the cases where people were sick but then appeared to be getting better and acutely declined, we're now much more on the watch for. And we have a lot more new treatments. We have guidelines and protocols for what we use. And even now we're doing studies on the use of convalescent plasma. So in conjunction with the Brigham, we are doing a study where if somebody is COVID positive, but and then give that to somebody who's sick and might not be doing so well, and assist them in fighting the virus. So having been now on the floor treating patients, the people that, there are people that have been incredibly sick that I would not have really had much optimism for, that are doing perfectly well. The ones that are passing on are ones who are very old, very frail, often from nursing homes, multiple other medical conditions. And so their body is just shutting down. So younger people, they're generally doing quite well.
Yeah, so the way I think about this disease is I really am breaking it down into four groups of patients. You have the first group, hardly even know that they're ill. So those are the ones that we'll find out later that their antibodies are positive, but they have they had very little illness, and why that's happening we don't know yet. The second group have the mild respiratory symptoms, the fever, the cough, the fatigue, and then are managed at home. Never have to go to the hospital, and never need the emergency room. Never get short of breath. The third group And the fourth group are the ones that end up into the hospital where Bob is seeing. So these patients, usually usually around somewhere between day 4 and day 10 of their illness, they are developing rapidly progressive shortness of breath. And they are showing up in the emergency room. So group 3 never require intubation. And there may be that group of 3, that group where they're never required, is getting larger. So the people in the hospital are learning new techniques on how to prevent people from progressing into that to the point of needing the ventilator. And then obviously the group 4 is being on the ventilator, and sometimes obviously they're not getting off. That can be a very high mortality rate, but that mortality rate is shrinking as we learn again more and more about this. But they're also staying on the ventilator for sometimes as long as 3 or 4 weeks, which is much longer than a typical pneumonia if people come in and have respiratory failure from pneumonia. Now, what we've learned over the last, really over the last 6 weeks, is that the people that are developing that severe shortness of breath, it's because of internal clotting that has started because of this cytokine storm. So you're literally clotting all your vital inside your vital organs. So so obviously if blood is not circulating through your lungs because it's filled with clot, you can't breathe. If your heart vessels are filled with clot, you're having a heart attack. If you have clots in your brain, you're having a stroke. A lot of these patients, and I'm sure Bob will attest to this, go into kidney failure because their kidneys are filled with clot. So I see some from the chat that the question is, why are some people having why is some people having these clotting conditions and others not? That's that's probably genetic analysis, other diseases they've had that confer them some immunity. But that's part of this grouping, but this 4 grouping, that's how I think about it. And then as I'm talking to my patients, trying to think about, which group may they be in and how do I advise them?
Yeah, it's fascinating. I'd love to hear sort of a higher level of how has your vocational calling been affirmed in this time, or how has it been challenged? I can imagine being a doctor in these times are incredibly stressful, but there may also be great rewards in that. I would love to hear your perspective on that role of being a physician in a crisis, and what advice would you have for some of our students out there who are pondering this field?
Bob?
Do you want to go first? Do you want me to go first?
You go first.
Oh, thank you. I think from a vocational calling, there's always one of the challenges that I think we've always faced, particularly since we don't practice in a vacuum. So as a clinician, we're all very much dependent on a lot of other clinicians and a lot of other people that contribute to how we deliver care. So the nurses, work incredibly hard to do things that they need to do, without which we would not be able to have much impact on patients. And the pharmacists, in terms of, balancing out a lot of these new medicines, many of which we've not used in years, or in some cases are brand new. And I think that the challenge prior to this is with the business piece, with the competition between different places, you often felt like the business part of medicine was taking over and, obscuring the vocational piece. And now it's back to the vocational piece. It's about providing a service to patients. And so, particularly now where people are scared, to be able to go in and provide a touch or is a great source of personal satisfaction. I think at least in the moment now, it's all about taking care of the patients. And hopefully we'll continue with that focus, and we'll not worry so much about all of the Medicare cuts and all the other stuff that, tend to obscure what we do.
Yeah, so and everybody that's working in all the different fields of medicine, and from the housekeepers all the way up to the neurosurgeons, and everyone in between, is that there's a great esprit de corps at the hospital, where everyone is really looking out for each other and helping out with the difficult cases, and just really just recognizing that this is our time to shine and take care of incredibly sick patients, and just where I think everyone feels like they're doing an important part for our neighbors and our friends, and there's even doctors and nurses getting sick that are, needed to be nursed back. In terms of, my little plug for medicine is that you're given you learn an incredible a large amount of information that you then need to synthesize when you hear a problem from a patient that is struggling with something. You come up with a plan, sometimes wonderful feeling to be able to use your mind and your knowledge and your skills, and then 20 years that Bob and I have been working to actually help people. And one of the things I counsel people in the office in terms of just feeling better about yourself, it's very hard to give self-care, right? To do self-help. I think that the best self-help is to help other people, right? And that's one of the things I really encourage people to do. And so I think that's something that us as physicians, we get to do all the time. And I think we get a lot of gratification. Obviously we have the failures, which are those, we all feel those whenever we lose a patient. You remember those forever because you always reach, but can never. And we do feel that every time we lose a patient. So and obviously this is accentuated during this time.
Bob, to talk a little bit about what the pressures that the hospitals are facing right now in regard to, we heard a lot about PPEs and what is it like day to day in there? Quarantining patients, that flood water. Have we reached sort of that surge? Give some perspective to people out there.
Sure. So, I think that a lot of the position we find ourselves in now have a lot to do with where we started from. And so the hospital in general, a well-run hospital, has a margin of somewhere around 2%. So you spend $100 million to collect $102 million. And a lot of that is really dependent on how the insurance companies decide to reimburse you or compensate you for things. So the CMS looking and saying by 2030, they estimate that a quarter of the US population, 80 million people, will be on Medicare. And so as the population ages, and right now the percentage of people in this country over 65 is higher than the number under the age of 18. So the pyramid scheme of being able to have younger people pay into Medicare or Social Security and using that money to care for people obviously isn't going to work. So consequently, CMS Medicare has cut down on the budget to try to force, more judicious use of care. And to be fair, there's definitely room for improvement in quality. However, it also means that we have limited inpatient capacity. So the South Shore Hospital, which essentially is the largest community hospital, certainly we're bigger than BMC, we're bigger than Newton Wellesley, North Shore. We have all in about 456 beds, serves as the majority of the South Shore. So we offer a higher range of services, we bring more people in, but we only have, of those 456 beds or so, 300 med-surg beds. And so it's not uncommon in the best of times that we have people lining the hallways trying to get into beds. So now with the COVID, and what we've learned from this is that people just don't get better quickly. It's not unusual to have people in the hospital for 10 or 12 or 14 days because the inflammatory process in their body gets better as quickly as it has. It gets better as fast as it's going to. We can't necessarily speed it up. So our challenge has been, how do we support people realizing that we're running an operating loss month after month after month? And the money that the federal government has earmarked to come to hospitals in Massachusetts is in the form of a loan. So we have to pay it back. And so we're in a pretty good shape compared to most hospitals in terms of our margin, but that margin was shrinking year to year to year anyway. So there's real concern about whether or not various healthcare organizations in the area are going to survive because of the economics of how healthcare works. From a point of view of the COVID folks, it has, again, the focus has always been take care of the patient first. And one of the things that I'm very proud of in the institution that I work is about patient care first. And there's never been an instance where somebody has ever tried to get me to do something I didn't feel was in the patient's best interest because the money was, there. But that's not the case everywhere.
That's great. Tim, what's your perspective dealing with patients right now? How are people managing the anxiety, distress, the worry about, am I sick, or am I my gallbladder, or this? Everyone already had all kinds of ailments, and now people are afraid to maybe go to a hospital or go see a physician. So how are you managing outpatients in this period?
Sure. Well, I think the anxiety was sort of at its peak in late March to mid-April. Everyone was very much at a much higher level of alertness, and we've been starting to see a little bit more as people sort of getting the sense of how they can protect themselves. There was so much mystery out there early on that this was everyone keeps telling me it's the unseen enemy. But there are people are learning the strategies now of how to protect themselves. But now we're getting to the phase of, well, we can't not only can we not shut down the economy forever, we can't shut down routine medical care forever. So we are starting to reach out. Well, we've been reaching out to our patients for the last 3 weeks to start our diabetics, our cancer patients, people with high blood pressure, lipids, and say, yes, it's okay to go to the lab and get your lab work done. It's okay to go to the pharmacy and fill up your meds. And we're also starting to get the worry about, did I already have it? And they're talking about the antibody testing, right? Everyone wants to get tested for the antibody. And that's a whole nother bag of worms because, one, we don't know if the antibody tests work. And we don't know if it's positive or negative. We don't know how reliable that is, and we don't know if you're immune, if you've had it. And we're just so early on that Bob and I are probably only 2 or 3 steps ahead of the general public in terms of medical knowledge, because we're reliant on all these large studies, and they just haven't been done yet. It's still, literally, it's the information is coming out on a weekly basis. So that's one of the harder things, is just trying to be accurate with our information when the information is changing on such a rapid pace.
That's great. I got one more question, then I'm going to move it to the rapid fire round, because I got a bunch of different questions that have been coming in here. So we're a Catholic school. Talk about how faith fits into your role as a doctor. How has that been part of, maybe your calling or the work that you do? How do you manage your own personal faith in your roles?
I think faith was incredibly important in terms of my choosing to become a physician in the first place. And, my father, who was a product, dare I say it, of the Jesuits, used to say, to whom much is given, much is expected. And, talking about, if love your neighbor as yourself. So you have to have some faith in order to deal with all of the things that you see that don't necessarily make sense. The children who are dying of cancer, the stuff that comes in where you look at people who have various addictions or alcohol problems or victims of domestic violence, and your brain, from a logical point of view, it's hard to make sense of that. From a faith point of view, you have to step back and sort of realize that, my job is not necessarily to tackle all that. My job is to do the best I can to take care of the person in front of me. And so you have to, with faith, realize that, you need spiritual strength. So you need the Holy Spirit to come in and help you make the decisions. And there have been times when essentially I've been tempted to say something and felt a nudge to say, yeah, don't say that. Or suddenly have thought that there's, oh, wait a minute, I didn't think of this. And that turned out to be the right diagnosis. So I think that it's very important to have set strong values and also a strong sense of commitment. And that's the primary, qualifications, I think, to be a physician.
That's great. Tim?
Yeah, and certainly in my experience, faith really led me to being a physician. I have to be honest, is that in college, high school, college, my faith was a little shaky during those times of my life. But it was after college, I met my wife, and together we really embraced our faith together. And it was during this time that I really started to feel that nudge towards medicine. And the more I prayed about it, the clearer my path became. That I developed this clear path in my brain that I was going to go to medical school and I was going to become a doctor. It was through praying. And so that has led me to now where we pray every night with our family. And then certainly through my whole career, and especially over the last 6 years, where I've done a lot of the hospice work, where I've dealt with a lot of death and seeing people approaching death, and talk to people that have had visions of their loved ones that have coming to visit them. You hear that, when you hear that over and over again, that really does, strengthen your faith. And I think we need our faith right now, because this is a very, very difficult time, and for everybody. And we need to be praying and asking for guidance, and then also praying together to help the victims and help the world make the right decision. I think that these are incredibly important times.
Yeah, that's really beautiful. Thank you. Very powerful. So these are some of the questions, and I know there's some panel and people are still chatting some, but let me put some that we had in advance. So as you think about this focus has been on COVID-19, has that had any impact or consequences in your view on delayed cancer therapy, treatments, or research? And, is there an unintended consequences?
What happens when there's a state of emergency declared, okay? It gives the governor certain powers, it gives DPH more control, and population, and what's best for the group population is more important than what's good for the individual, which is why people are told to stay at home and told not to go to work, and which can be a very big hardship for many people. So all elective surgeries, anything that is potentially postponable gets postponed. We are still doing emergency surgeries, but anything that is not an emergency, we really are prohibited from doing by DPH. So with the governor potentially opening things up on May 18th, there's a chance that we start to bring things back in. People are still getting surgeries. They are still getting some chemotherapy, but because chemotherapy, and I'll apologize to any oncologists in the audience, is really a game of chicken, where they give you an industrial grade poison with the idea that it's going to kill the cancer cells faster than the healthy cells. So if somebody has an underlying infection, it knocks down the body's resistance. And so now all of a sudden you may find that dose of chemotherapy actually caused all sorts of other problems. So there's been some hesitancy, and I know that there's less volume, there's less of that being done, but it's because of the right reasons.
Right. Actually, there was an article or editorial in the journal Lancet this week that was estimating that there was going to be a 5 to 10% decrease, or actually increase in mortality from cancer diagnosis because of this brief halt in screening. So I think there's been definitely a messages being sent that we, just like I mentioned before, you can't shut down the economy and you can't shut down routine screening and routine care. So I think this is a worry. We want to get back to screening our patients, caring for our cancer patients, caring for these quote unquote, non-emergent cases. But, we don't want to convert patients that have a curable condition and then by delaying have that now become a incurable. which would obviously be devastating. So I think we're, just like we're starting the economy back, we're going to be starting the routine care back as well.
Yeah, and this is sort of a related question. How do you feel the healthcare system will be prepared for the inevitable throngs of preventative screenings, appointments, procedures that have been put off? Just like everybody else, do you think there are enough doctors and healthcare professionals to absorb what will be, I guess, another high tide, maybe?
Well, I know from Newton Wellesley, there have been, just as they were preparing for the surge, they prepared for the surge of cases. They're actually now preparing for the return to more normal operations. So that is something that they're starting to start to make the planning for. I think there's just no way to plan for the actual event. You can try to anticipate as best you can, but until the event actually is upon you, you're just never really sure if you've done enough. And I think that's going to be the case. This is what you're going to find through this whole process, is that you're going to constantly learn from your mistakes. You're going to try to make few as mistakes as possible, but then try to learn from them and adapt.
What's your take on the rapid tests or the antibody testing? And do you think that will be a prerequisite maybe for people coming back to school?
About the rapid test. So the test is really the same test. It's just that our ability to process them faster has gotten much quicker. But it's the same test regardless of where it's done. But if you came to the hospital and your test got sent to Quest, the turnaround time might be 18, 24 hours. If we were able to do it on site, it might be 2.5 hours. But in terms of how they do the test to get the results, it's pretty much the same technology that they're using everywhere. In terms of the antibody testing, that's a whole rabbit hole that we need to be very careful about going down for a lot of reasons. So generally, people think about antibodies as being protective against an infection. And for some viruses like measles or mumps or chickenpox, if you've had the infection or have been vaccinated, that confers an immunity that's actually quite good in many decades. But in other situations, like the flu, it turns out that even getting the flu shot or having the flu will not prevent you from getting the flu again because of the way it mutates. So because we don't know that much about the coronavirus, what we know is that there are a lot of people who have antibodies that are asymptomatic. But do those antibodies confer protection? It's not entirely clear. Not only that, there are people who have had the infection, bona fide, documented, proven infection, but have had no antibody buildup in their body even 3 to 4 weeks after the infection.
Wow.
So we're left with the fact that, yes, we can test antibodies, and many people are kind of demanding the antibodies. But the issue is that, well, what does having the antibody test mean? And I think that we have to be careful about using that as the sort of, trigger to either go back to work or not, because it's based on a lot of assumptions, which we haven't validated yet. So I don't think that, I don't think at the moment, if somebody asked me, if they had the antibody test, does that mean that they don't have to worry about precautions? The answer would be no. You still need to use all your precautions. And in fact, Mass DPH, unless they've changed the regulations in the last 24 hours, if you have not had any infection but had the antibody test positive, they're taking that as proof of active infection, and they're telling you go quarantine yourself for 10 days. So we've actually had people telling them, don't go get tested for antibodies for the hospital, because we don't know what it means. And we don't think it means that you have an active infection, because it doesn't make sense from a science point of view. But since DPH mandates it, you could have the police show up to your house and say, yes, we're here on the part of DPH, you can't leave your house.
Sure. One of the questions that we just received was, can you speak about why some patients, even young, healthy people, are so hard hit by the virus as opposed to some who just have mild symptoms? Any thoughts on that?
I think it's going to come down to genetics, most likely. Yeah, and this will be something that'll come out over many, many months. And I think the reason that they're having this poor outcome is the clotting. So really, that's what it's. So it may be that they have a genetic predisposition to clot that they were not aware of. That these young people had the virus, instead of just having the respiratory symptoms alone, they got the clotting complication, which led to the severe breathing difficulties and the whole multi-system disease that we see so much in the news, is people showing up in the emergency room. That's what we're going to find out. We don't know enough about it yet. So I think that's something that's going to be elucidated over months and likely years.
Yeah. Any thought on demographics, nationalities, race, that, some groups are more akin to this or not, or reacting differently? Population?
Well, we certainly know that, we're seeing reports that the African American population seems to be affected at a higher rate. We also know that, we certainly know that there's a higher rate of high blood pressure in the African American community. There's also a lot of that community is living in closer proximity as well. So we don't, we're trying to piece that together as well. We just don't, again, we just do not know enough about all of that. But those are some of the risk factors that we're aware of right now, but we don't, literally, we're going to be writing about this for 20 years in terms of studying what's been happening, and we're only into this for, like I said, 4 or 5 months. So I think that that's what's so frustrating for physicians and for the community is how slow the information is to come out, and it's because it's so complex and we've never seen it before. And in terms of what Bob was saying, about getting back to school and back to work, I think we're going to be wearing masks for 18 months, 2 years. That's my estimate. I think that to get people back to work, there's going to be, and to school, there's probably going to be something, you're going to have to strategize. Or are people going to have to live in single rooms? Or they, forget about, roommates. Are they going to have to stagger college? They're going to, and everyone wears masks at work and so forth. I think these are the strategies we're going to have to think of. Not only is it a new normal, but we're going to have to come up with solutions that we just never thought possible, that we would not do before. Because you put a stress on a system, that system will figure out a solution, but we just haven't figured it out yet.
Well, if you could look into your crystal ball, right? What do you see for the next, through the end of the summer and project into Christmas time? And then Tim, I'd love to hear your thoughts.
So I think, going forward, and this will be a wag, as we like to say, a wild ass guess, because again, I don't have my crystal ball, but I think things will start to open up, particularly as the summer comes. And I think that they are predicting a resurgence in the fall. And they are predicting as well, and we're preparing for, COVID, sequel to COVID, son of COVID in next potential winter. Now, whether or not that comes true is unclear, but I think certainly being prepared is okay, is the smarter play than having it take you by surprise. I think a lot of what we might see is going to depend on to what extent they loosen the restrictions on social isolation, but also state-to-state travel. So unfortunately, or fortunately, Massachusetts is blessed with a great beach area and Cape Cod and all that other stuff, from which people come from all over the world. And so the risk is that we may be doing a great job with social isolation, but if somebody comes in from another part of the world that they don't have as much, they can transmit it again, and they may not even know that they're sick. So I think we have to be very careful about not, we all want to go back to business as normal, but I think we have to be cautious about what the new normal may be going forward. And I do think that much as, I think people don't want to really hear it or deal with it. I think a lot of the large social gatherings that have taken place in the past are going to be severely restricted. I think that if they decide to open up the restaurants, they're probably going to keep it capped at a certain volume of people, because again, it's all about preventing a resurgence to the extent that you can.
Yeah.
And what's your perspective? Those are great.
Yeah, I totally agree with Bob. I think we're going to have I almost think of it like the eye of the storm this summer. we're going to be in that eye, where all of a sudden the sun comes back out again, and you think, oh, we're okay, right? But then the fall comes again, and we're going to have a resurgence of this disease. People start, the weather's colder again. People start to come inside. We've loosened up the social distancing, and we could have, we would likely have another surge. It could even be worse than the first one if we're not careful. My thoughts on this are, this is a long haul. There's not going to be, I pray for it. I really do pray for an aha moment where we have the treatment, we know how to beat it. People get sick, we give them this medicine, and it all goes away. But I really don't think that's going to happen. I think it's going to be an incremental understanding of this disease through many, many months of trial and error. I really do think it's going to be, I think it's going to be 18 months to 2 years before we get to know, that where we have very few deaths every day from COVID-19. Now, are we going to be exactly like this? Probably not. I think we're going to adapt as a society, right? Because we know from the virologists that it takes, to get a disease under control, you need to have 60% of the population that is immune. So either 60% of the population has to get sick and be immune, or 60% has to have a vaccine that's effective. So I don't see that happening anytime soon.
Yeah, I'm reminded of, the polio epidemic, right? And how FDR created those presidential balls, and the March of Dimes was really created to cure that disease. Talk a little bit about how you think this vaccine, we're approaching it differently. I think it's almost an open source process.
Right.
Do we think there's hope for that within the next 12 months?
I think there's a hope that there will be a smorgasbord of treatments, depending on which stage of the disease you are. Remember, I almost had that grouping, that 1, 2, 3, 4. There'll actually be a different strategy depending on which group you're in. The first group will be, the isolation. The second group, maybe one type of treatment, and the third and the fourth group, we've already learned a tremendous amount just in the last 6 weeks about how to treat this. I think that's what we're going to be seeing is small little discoveries, incremental, that usually are happening on a yearly basis. These discoveries that I talk about in terms of other diseases sometimes come out every 6 months to a year. We're learning, and there's so many research institutions attacking this disease that we're seeing treatment strategies and paradigms coming out on a monthly basis that would normally be every 6 months to a year. So there is hope. But I think that it's, but you just have to steel yourself that, I guess the saying is, you hope for the best, but prepare for the worst. Right. And I really do. Unfortunately, that's where we're relying. The other phrase that you think about is that, pray to think that it's all. I'm not going to say this correctly, but the pray that like it's all on God, but work like it's all on you, right? And I think that's, I paraphrase that, but that's my thinking.
Bob, any final thoughts from you?
I think, there's a lot of back and forth between, sort of the public stance statements about how fast a vaccine may come out there. There's a great deal of pressure. There's obviously great stakes for the company that can come out with the first effective vaccine, and people are working round the clock to get that there. But again, the COVID-19 virus between Wuhan and Italy over to the US has already had at least 8 mutations the last time I saw. So even a vaccine for one doesn't mean necessarily protective against the others, or maybe it's only partial protective. So I think we can't put our faith all in the vaccine and what we're going to develop. I think that there may be other treatments that come along, but the best protection is to, be defensive in terms of washing your hands by far, washing your hands and keeping yourself clean, and wearing masks, not taking any chances. and then also staying, healthy and fit. So part of the reason that the younger people may be getting into trouble is that, they may have predispositions, underlying asthma. They may have a history of smoking, even though it might not be recently. There's anecdotal stuff from some of the ICU people that the younger folks who have vaped, for example, just destroys the lungs, and they are just a setup. So, there are things that people can do to stay healthy, and it's very much a day-to-day. It has to become a lifestyle.
That's very helpful. As we think about our school and as we're planning, someone had posted, we are actually looking into the CM dress code and the requirement of face masks, and actually researching with some companies to produce our own for students that would be required. So, the only thing that I've come to expect is that things are going to continue to change and evolve. And as a school, we're trying to train our students to be problem solvers, to head into a world that's rapidly changing. That fourth industrial revolution is here. I think what we think about all the time is creating problem solvers, creating people who can take a liberal arts education and apply those ideas to different problems. And that's what we're trying to do as a school. Try to think about how we're going to solve these problems, how we're going to continue to be nimble and educate our students, be thoughtful in our approaches, so we can provide the best safe education for our students and help make sure that they're becoming who they're supposed to be. I can't think of two finer graduates of our school, two men who have dedicated their life to a profession and that fits with the charism of the Christian Brothers, our Catholic faith. So on behalf of Catholic Memorial, the faculty, the staff, our students, and the alumni group, we're so grateful that you guys would take time out of your incredible busy schedules to share your insight with the school. So I just want to thank you again for what you're doing. I want to thank you for all the lives that you've impacted.
Can I just give one plug, Peter, before
Sure.
we end? So, the question always came up about encouraging younger people to go into healthcare. And I think that there's this misconception that healthcare is only for the brightest of the bright and the most dedicated to service. And I think the reality is that there's been a lot of discouragement along the way. Really, it comes down to people just deciding that's what they want to do. And so when my sons were faced with what am I going to do with my life, I brought several of them in to just meet the doctors. And the number of people that did almost any number of things before they went into medicine. One of them was in commercial real estate in Russia. He's an American-born guy, grew up in the Scituate area, who went to Russia to, basically flip houses there. And after 12 years of doing actually quite well, decided he was going to come be a doctor, came back to the U.S. And that balance is huge when he finds that now he knows what he wants to do. So I would encourage anybody who is really thinking about going into healthcare, is that the world will be filled with naysayers. There's a lot of pressure. No, you can't do that. Not to listen to them. If you know in your heart that that's what you want to do, I would say that it's still a wonderful profession. I'm never bored. I go home, I would say most days feeling content that I made a difference in somebody's life. And that has been that's what the profession is.
Yeah, I would second all that, and I think that the most important thing to have to become a physician is the desire to be a physician. That's it sounds stupid, but what it means is that I've seen people that were not the greatest students, but just had that drive to be a physician. And they ended up turning out to be fantastic physicians because they care. They care. So having somebody that is book smart but doesn't care, I don't want them as a physician. I want somebody that knows their limitations, and maybe there's somebody who always goes back and checks things 2 or 3 times, but they care because they don't want to make a mistake. They care about their patients. They get to know their patients. They hold their hand. That's the physician I want, right? And it is a fantastic physician. Position to have in society, and I wouldn't do anything else.
Well, you guys are great role models for our students, and you make us proud. And I have to say, Tim was my family's physician for both of my parents, and the love and care and attention he gave to both of my parents is something that I'm eternally grateful for and will remember well. So
Yeah.
you guys are incredible models, and I'm grateful to have you, what I consider now as friends and alumni. And thank you to everyone for joining the call tonight. And we'll end all things as we do with live Jesus in our hearts forever. Thank you guys
Forever.
so very much.
Have a
Thank you,
good night.
Doc.
Thanks.
Yep. Be
See you,
well.
Bob. Bye,
Yep.
everybody.
Bye.
Stay
Bye-bye.
safe.